Just a moment or two. Thank you. Marty Goldman, welcome to May 1st, Friday, the end of another week, probably around the 7th or so that we've been on COVID time. And I want to thank everyone for all their hard work, diligence, dedication, devotion, and particularly I want to thank everyone who has contributed to the educational format. Obviously, it's been a little bit challenging, and what's very gratifying to see is, we'll have anywhere from 50 to 70 or more people on these Zoom conferences. So I hope that the content has been satisfactory and has been helpful in to give some degree of normalcy in these very tumultuous times. In that regard, I'm really very pleased that Dr. Jeff Olin has agreed to give us the conference this morning, and is a breath of fresh air. He's going to present illustrative cases on vascular disease. But because of his expertise, I did want him just to preface his formal presentation with some informal remarks about what he's seen from a vascular point of view, venous thrombosis point of view, during the time of COVID, which is different, unique, and distinct for this disease, and also sort of his guidance on to do with patients, now that we're seeing patients in the hospital or at home with milder COVID who still have high inflammatory markers. How long should we continue oral anticoagulants for them? Jeff, again, welcome and thank you very much.
Thank you, Marty. Good morning, everyone. It's nice. Actually, the attendance is better than our normal conference, so that's good. I'm going to present 3 cases, and then at the end, I have about 3 or 4 bonus points if you get them right. I have a really good gift for whoever gets them completely right. Of course, if you come to any of my conferences, no one gets them completely right ever, so I haven't really picked the gift out yet. I will say a few words about COVID. I specifically did not want to talk about COVID because we're all COVIDed to death, but Marty asked me to say a few words about the vascular issues that we're seeing in COVID, and they're predominantly related to thrombosis, and it's typical thrombosis like DVT and PE, but it's also, especially in the lungs and the kidneys and probably the brain, microthrombosis as well. And this is thought to be mediated by the acute inflammatory state, which causes endothelial dysfunction, and it leads to all kinds of perturbations in the coagulation cascade. Now, John Halpern and I have worked together on a piece that is going to be part of a series in JACC on the issues of thrombosis, what we knew at the time, but it's changing every single day. A couple of things are clear. You can get both arterial and venous thrombosis with this. So I've seen occluded coronary arteries that are all thrombus, occluded leg arteries that are all thrombus. We recently had a case of bilateral renal artery occlusions and a celiac occlusion, but the patient was in atrial fibrillation, and it's hard to know whether it's COVID or not. I think most people suggest, there are studies that suggest that DVT occurs in about 30% of these people, 40% in some series. And it's now clear that people who are on anticoagulation have a better outcome than people who are not on anticoagulation. And the issues are like, what's the dose that you use? Do you treat them with full dose or prevention doses? And these things are all being worked out. So most people you'll see in the hospital are on something like enoxaparin. Occasionally apixaban is used, or if they have an acute pulmonary embolism, unfractionated heparin. And then the issue of what you do when they go home, they probably should go home on some anticoagulation. Studies on non-COVID patients suggest that rivaroxaban for 35 days or so helps prevent recurrent DVT. So that seems like a reasonable program. I don't think that's been shown with apixaban. The acute kidney injury that occurs with this is also microthrombosis, at least a large part of it. So the virus gets in there, there's a lot of endothelial dysfunction, destroys the tissue, and initiates thrombus. Many times when you get rid of the thrombus, like we did by administering TPA to a number of people in the ICU, the patients improve for 3 or 4 days, and then they go downhill again because there's been so much destruction of the lung. So all of this we're learning. Every single day there's new reports coming out. Some of them are not very good. And I can tell you that we've had many, many, many papers submitted to Jack about COVID and vascular disease. So I think I'll stop there. And unless anyone has any questions, and then move on to the cases. Are there any questions?
Do you follow the inflammatory markers in the outpatients to determine how long to continue it? And then let's say when they normalize, continue it for another 2 weeks, just to help resolve whatever microthrombi may be there?
We look at D-dimer, but I don't think that would be the main determining factor. I think the recommendations now are, and again, they're changing every day, that you send them home for a month of anticoagulation. If they haven't had a DVT, it's preventive doses. If they have, it's full dose. If they've had a DVT, you keep them on for 3 months at least, and possibly longer. And then you may use D-dimer as a guide to whether or not you can continue them or stop them.
Thank you very much, Jeff.
Okay.
Jeff, sorry, Jeff, this is Vivek. Can I ask you one more quick question?
Yeah, sure.
If one of the major problems is the endothelium, are there any putative agents that you can think of that people should be investigating to try to, I don't know if stabilize is the right word, but whatever the right word is, to affect the disease favorably?
Well, I think the endothelial dysfunction is a result of the very, very acute inflammation that occurs with these patients and the cytokine storm that occurs. So I don't think, first of all, there are no good drugs to fix endothelial dysfunction, except if you have hypertension and you treat it, it improves it. But in this case, it's all immunologically and inflammatory mediated. So there's no drugs that definitely correct that I'm aware of.
And how do you square that if, as you know, many of these patients are presenting with thrombi, or at least I assume that's early in the disease process, at a point where, at least if you look at systemic anti-inflammatory, markers of inflammation, they're not particularly high, and yet they're having thrombosis. You know what I'm saying? Or is it a micro versus macro?
Well, I think it's both, but the people who have the highest mortality are the ones that have very high D-dimer levels and very high C-reactive protein. I mean, these levels are much, much greater than you see in other thrombotic conditions. So we don't really know a lot about the asymptomatic early patient who has COVID and what their markers are really like, because most of the studies didn't look at those patients.
Thanks.
Thank you, Jeff. And
Okay.
thank you.
This is a topic I never talk on. And I saw that Sean Kotkin is on this call, and if he is, I would refer all your swollen legs to him. He's an expert. So I don't talk about this because
Thank you, Dr. Olin.
I don't want it to be predominantly my practice, but this is one of the most common things that a cardiologist will see. And other than administering furosemide, not much is done. So most of the time, they come into the cardiologist's office with swollen legs. They're given furosemide. They don't get better. They're told to get a compression stocking. They don't get measured for it. And then the patient's not really taken care of. If you happen to be at a place like Sinai, where there are people like myself and Dr. Kadian and Dr. Kotkin and a number of the fellows who spend a lot of time with us, they know how to logically approach this. So looking at this guy, he's obese. He has swollen legs. His feet are relatively spared. And he has skin changes of chronic venous insufficiency. So I think, and this is often not done, I think there are certain things in the history and the exam that you should do. When did it start? Where does it swell? Does it swell in the feet or the toes? Does it swell above the knee? Because if either of those occur, it rules out about 3/4 of the causes of leg swelling. For example, venous insufficiency does not swell above the knee unless you have an iliac vein obstruction. Do the feet swell? Do the toes swell? That's a very common thing in systemic causes of edema, such as heart failure, nephrotic syndrome, cirrhosis, but it's also the sine qua non of lymphedema. Has the patient ever had cellulitis? Because cellulitis is a major cause of secondary lymphedema. Is the swelling painful? Most swelling is not that painful, but people who have lipedema, and I'll show you that, it's fat deposition, they complain of a lot of pain. Is there a surgical history of abdominal pelvic surgery or radiation therapy, and how much weight has the patient gained in the last year? Systemic causes, history of heart failure, history of nephrotic syndrome, history of cirrhosis, acute or chronic kidney disease. Has the patient ever had a blood clot? When and where? Has the patient ever had vein surgery? For example, coronary bypass surgery or vascular surgery or ablative surgery? And then is there any history of trauma? So I think if you do this history, you narrow down the causes substantially. And then it surprises me how many people don't have a urine analysis or thyroid tests who have leg swelling. And I've seen a number of cases of nephrotic syndrome who are sent because of leg swelling. The second, probably the most important questions about the history is medications. There are 5 groups of medications that can cause swelling. The non-steroidal anti-inflammatory drugs. And it's been estimated that 20% of people on ibuprofen who are on prescription doses have leg swelling. The calcium channel blockers, particularly the dihydropyridine ones, but also direct-acting vasodilators, alpha blockers, thioglitazones, and the gabapentin class. And this is dose dependent. For example, if you have patients on very, very high doses of this, you can see 4+ soft pitting edema in the legs, and it completely disappears when you stop the gabapentin. So a good history of medications is very important. Excuse me. And then on the examination, you want to pay attention to a few things. Is the popliteal artery enlarged? Popliteal artery aneurysms can compress the vein, cause DVT or venous insufficiency. Does the swelling go above the knee? As I said before, unless you have iliac vein thrombosis, it usually does not. It usually means you have a systemic cause of edema, such as a protein-losing state, nephrotic syndrome, heart failure, or you have lymphedema, which goes above the knee. Are the feet and the toes swollen? Lymphedema or systemic causes? Is there pigmentation around the area? Are there varicosities or large venules? You should examine the patient standing. Are there skin changes, like verrucous, wart-like changes of lymphedema? And then is there tinea pedis, and are there cracks in between the toes? Because this is a major cause of acute cellulitis, and this can lead to substantial lymphedema. So you want to treat that. Now, this lists a whole list of things that can cause unilateral leg swelling. Some of these can also cause bilateral swelling. I think you're familiar with most of them. I'll just point out a couple you may not be. Popliteal artery aneurysm, compartment syndrome, the swelling of dependency in people with neurologic diseases like spina bifida, who are constantly sitting with their legs hanging down. Rupture of the medial head of the gastrocnemius muscle. We don't see this much anymore, post-revascularization. It used to be they waited till the patient was so ischemic before they were revascularized, and then you would get a reperfusion edema, but you don't get that anymore. Factitial edema and complex regional pain syndrome. And then here are the causes of bilateral leg swelling. I won't read the list to you, but I just will point out a couple of things. Don't forget about drugs. Pretibial myxedema, I'll show you a case of that. Pregnancy, obesity, lipedema. So, not all patients with a deep vein thrombosis have what you see on this picture, a swollen leg with some suffusion to the leg compared to the other side. But when you see this, you need to think of DVT. DVT doesn't cause severe pain, and it usually is associated with discomfort when you're standing or walking. If you're in bed, the pain usually dissipates. So if you're having severe pain when the patient's in bed, think of something other than DVT, except if they have a condition like phlegmasia. Here are the classic findings of chronic venous insufficiency. So you can give these non-systemic causes of edema, you can give them diuretics till you're blue in the face at high doses. And all you'll do is cause extracellular fluid volume contraction everywhere but in the leg. So diuretics for this don't work. You have pigmentation here. You have the beginning of a venous ulceration. This leg is bigger than this leg. You have this corona phlebicasia, stasis pigmentation, and then a condition which is very painful called atrophy blanche. And this is due to microthrombosis in the capillaries and the postcapillary venules. This is really difficult to get to heal. Now, when you see this, you know that this, number one, is venous. The feet are not really involved. Number two, it's occurring above the inguinal ligament. And this is phlegmasia cerulodolens. This is markedly painful. You have, in this case, massively red, swollen leg. You may have diminished or absent pulses, and this is a limb and life-threatening emergency. This occurs, 50% of the people who have this have malignancy, and 25% have heparin-induced thrombocytopenia. This needs to be treated aggressively with either thrombolytic therapy, mechanical thrombectomy, or open surgical thrombectomy, or you'll lose the limb. So here's an early case of this. And what essentially happens in this is that blood gets into the leg, but it can't get out. So all the collaterals are thrombosed, and not only just the main vein. So eventually the venous pressure and the tissue interstitial pressure overcomes the arterial pressure. So if you did an arteriogram, you see a column of blood coming down, and then it would taper to a point, and that point is where you stop arterial perfusion. You know this is not a primary artery disease because the feet are puffy and you have distended veins. You would have collapsed veins if it was arterial. And this is what happens if you don't treat it. This is actually the first case of this I ever saw many, many years ago. And the patient was untreated for a long time. And this is one of the causes of venous gangrene. So phlegmasia needs aggressive management. You need to look for HIT. You need to make sure they don't have a malignancy. And you need to physically or pharmacologically remove the clot. And then if there are any areas that need angioplasty or stenting in the pelvis, you would do that.
Okay.
Now, most of
Now, I
the...
mentioned this early in this presentation.
What's
This
that?
is where the right common iliac vein,
Marty,
I'm sorry, the right common iliac artery compresses the left common iliac vein. Occasionally, you can compress the right too.
Marty, I'm not talking,
It's the
so I don't know why
reason
this is happening.
2/3 of all DVTs are in the left.
You may have audio on the slides. So if you shut the audio off on your slides, because you may have narrated the slides before.
Oh, I've never had that happen before. Anyway, I'm gonna forget that. That was May-Thurner syndrome, where the left iliac vein is compressed by the right common iliac artery. That's why 2/3 of all DVTs occur in the left leg. Now, this is an important condition, and when this comes into the ER, it's always treated the same way. It's treated as a DVT, and it's treated as cellulitis. And the clue is that you don't get these patchy areas of normalcy in DVT. So this has to be acute cellulitis. And this is mostly staph and strep. So not only can this cause a swollen leg, but this can lead to destruction of the lymphatic vessels and ultimately lymphedema. The most common, here you can see this area of normal and then areas of infection here. So it's important to look in between the toes. Most people don't do that. For tinea infection and for cracks in between the toes. And this person I just showed you had about 8 episodes of cellulitis.
People please put their phones on mute. The background noise is distracting. Thank you.
Yeah, 8 episodes of cellulitis in an 18-month period. His wife was a registered nurse, and I told him the portal of entry was this. They had cracks in between their toes. And when the tinea was treated, they had no further episodes of cellulitis. So it's really, really important. Cellulitis almost always occurs due to cracks in between your toes or ingrown toenails. Now, here's a case that I think a large majority of healthcare providers would say to the patient, go get compression stockings and this will take care of it. And those of you who have been on my service know what this is. This is not edema, but it's called lipedema. This is deposition of fat in the legs, hips, and buttock. It's bilateral always. It always occurs in women. There's never been a case I've seen that occurs in men. And the feet are spared. This is very, very important in differentiating this from lymphedema. And you have here what you call the ankle cutoff sign. So there may be a little fluid here, but the rest of this is fat. And if you touch it or squeeze it, they'll tell you it's very uncomfortable. So if you put them in a compression stocking, they'll be miserable. They'll never come back and see you. And they'll continue to have this problem. So this is enlarged buttocks, thighs, and hips. It spares the foot. It's bilateral and symmetrical. The fat pad sign down here does have a little bit of edema. The torso is relatively normal or disproportionately thinner than the lower extremities. It does not pit, it's tender, and it's frequently misdiagnosed as lymphedema. And really, every pound the patient gains goes into her legs, and every pound she loses every pound she loses comes from her upper body. So this is the reason why you ask them if they've gained weight in the last 5 years. And you also ask them if anybody in their family has legs like this. Unfortunately, there's not a lot you can do about it. There are surgeries, but they're very disfiguring. And you just have to tell the patient not to gain any more weight. But compression stockings do absolutely nothing for this. Really, all you need to do is education. That's as opposed to this. This is lymphedema. And you have a hump on the dorsum of the foot. Now, you get lymphedema in heart failure. Heart failure edema is both venous and lymphedema. But we're talking about either a primary or secondary lymphedema here. And the toes are swollen. This is gentian violet that she puts on. And these are the verrucous changes of lymphedema. So the classification of lymphedema is shown here. Primary lymphedema, if it's congenital, it's called Milroy's disease. Lymphedema beginning between the ages of 10 and 40 is called lymphedema praecox. And lymphedema tarda after the age of 40. Anybody who develops lymphedema after the age of 40 needs a CT scan of the abdomen and pelvis to make sure they don't have a malignancy or lymph node enlargement, etc. And then here are the causes, some of the causes of secondary lymphedema. So this is rather typical. She has it of the left leg as well. So it begins distally. So you don't see lymphedema starting up in the thigh, usually. There's a rare variant that does, but the toes, you have this buffalo hump. The toes are swollen. You start to get this wart-like changes on the toe. I'll tell you about stemmer sign in a minute. And this is classic lymphedema. Now, if you put a compression stocking on this patient, it's going to do nothing. And I'll talk about this in a minute. You have to get rid of the swelling that's present before you measure them for a compression stocking. Compression stockings only prevent the swelling from coming down. They don't get rid of it. So here's stemmer sign. It's the inability or failure to pinch or pick up a fold of skin at the base of the second toe. If it's positive, it's lymphedema. If it's negative, it's lipedema. I don't think you need a stemmer sign here to tell you this is lymphedema. And I don't think you need one here to tell that this patient has feet that look unlike any feet of the patients that I take care of. There's stemmer sign. This is Dr. Kadian's hand pinching between the first and second digit. Now, this is a pretty common cause of leg swelling. And if you misdiagnose this and put them on heparin, it could cause real problems. Usually it's a young, healthy patient. They're walking, they step off a curb or they move in a funny way and they hear a pop and they develop severe pain in the calf and the leg swells up. It's very, very tense. And when you touch it, I mean, literally they're ready to jump off the wall. So early on, you don't see this. But that history and the severity of the pain should suggest that it's a rupture of the medial head of the gastroc. And if you do an ultrasound on these people, you'll see blood around the gastroc tendon up below the popliteal space. And then a day or two later, blood tracks down the leg and forms this. This is the scimitar sign, and this actually confirms the diagnosis. The treatment is non-steroidal anti-inflammatory drugs, put a heel lift in the shoe or have them take weight off, and this takes, I don't know, 3 or 4 weeks to resolve, and it's very, very tender. So this, as cardiologists, you should all know what this is. And why am I showing this in a talk on leg swelling? Because these people with Noonan syndrome have lymphedema. That's one of the components of Noonan syndrome, along with the web neck and low set ears and funny face and pulmonic stenosis. And lymph accumulation in the lungs occasionally. So don't forget about that. Here's another cause. This is not rare. This is Klippel-Trenaunay syndrome. It's made up of 3 to 4 components: muscular hypertrophy of the leg, varicose veins, port wine stain, and 50% of these people have an arterial venous communication or malformation. And then it's called Klippel-Trenaunay-Weber syndrome. And really, the treatment of this is, it's difficult to treat, but you can do endovascular means to ablate some of the veins. This can cause really severe vaginal varicosities, etc. Don't forget about this. I've seen about 5 cases of this. Usually it's in a healthcare provider of some type, but the clinical clue is right here. So she's had swelling for 6 months and they can't find a reason, but she's been putting a tourniquet around her leg. Don't ask me why. This is factitial edema. And usually you have to confront the patient with it and they're going to need psychiatric help. But I've seen a number of cases of this where, and usually they deny this, but this is exactly what it is. And then rarely you'll see this. This is really, really hard to treat. I don't even, you know, I would send these patients to an endocrinologist. This is pretibial myxedema associated with hyperthyroidism usually. And even when the hyperthyroidism is treated, this still remains. And I would send these people to the best endo or dermatologist that you know. So this is localized thickening of the pretibial skin. It occurs with hyperthyroidism. You can see the rest of this. Now, if you only remember one thing from this, remember this: never put a compression stocking on a swollen leg. All it does is stretch the stocking. It doesn't get rid of the edema, and it makes the patient miserable. So you do some measure to get rid of the swelling. This is ACE wraps. Or you can use other devices, but you get rid of the swelling. You then measure them with the compression stocking. You decide the amount of compression they need, and sorry, misspelling, and you tell them they have to put it on in the morning when they wake up, and they have to, and then take it off when they go to bed at night. If they walk around without the stocking one day, the leg swells up again. You have to rewrap the leg before you put the stocking on. And then there are other types of garments that are used, such as this, the circate garment. It's good for older people who don't have the strength or can't bend over. And this is a Velcro type of situation. This will get rid of the swelling because you can increase the compression. So we went over the causes of swollen legs. I'm not going to belabor that, but remember, if you have any patients with that, Dr. Kotkin, he's in Queens, he's an expert. The swollen arm. If you saw this is a 22-year-old or 23-year-old, onset of swelling for 2 days. He plays tennis and lift weights. What's your diagnosis and what's the cause? The diagnosis is readily apparent. There's nothing else that causes dilated superficial veins like this. This tells you this patient has axillary subclavian venous thrombosis. It also tells you that he looks like he's young, so the most common cause would be thoracic outlet syndrome, which is also effort-related thrombosis or Paget-Schroeder syndrome. Central indwelling catheters or pacemakers are also major causes of this. Now, here's a guy who did not have clot thrombosis, but his arm swelled. And they're doing an Adson's maneuver here, and you're seeing that the main subclavian vein is being compressed, and these collaterals develop immediately and they disappear immediately. So this area is very, very well collateralized, and rarely do patients with this continue to have swollen arms even if you just treat them with anticoagulation. Do upper extremity DVTs cause pulmonary embolism? Yes. About 12%, maybe 14% if they're untreated, whereas the lower extremity proximal DVT, it's about 50%. But they do, and they should be anticoagulated. This guy, for an older gentleman, has the best collaterals I've ever seen. Usually, older people get these little venules up in their arm here. And the cause in him, you can see by the white arrows, he has a pacemaker. And the fact that he has such well-developed collaterals keeps his arm so it's not really, really swollen. And you may not need to do anything with the pacemaker if it's working and everything's going fine with it. And here's an example of a pacemaker resulting in severe venous hypertension due to an arterial venous fistula that occurred at some point during this. And this is bad news when you get this, because then they start getting ischemic changes and ulcers, and something needs to be done about it. So if you have a 75-year-old person who has subclavian vein thrombosis, and their arm is not terribly swollen and they're not in a lot of pain, I would just treat them with anticoagulation, and they'll develop good collaterals and they won't need anything else done. However, if you have a young person who's active in sports, or if it's their dominant hand, and whenever they use it, it swells, or you see this a lot in Major League Baseball pitchers. David Cohn had arterial thoracic outlet syndrome. Oil Can Boyd had subclavian venous thrombosis. Steve Reed from the Indians had arterial thoracic outlet, and he embolized to his fingers during the American League playoffs. So those kind of people you have to treat. And we treat now predominantly with catheter-directed thrombolysis and mechanical thrombectomy. In order to prevent recurrence, they then need to have a first rib plus or minus scalene muscle resection. And this can be done by multiple approaches. And then anticoagulation and physical therapy for 3 months. And here's just an example. You see this big collateral up here, and you would think that they wouldn't need to have anything done, but this person was very symptomatic. So occluded subclavian vein. This is post-thrombolysis. And what happens with many of these people is they get a fibrous band here. And after you fix, do the first rib resection, then this needs to be taken care of either at the time of surgery with a patch angioplasty or post-surgery with a stent. And then the patient will do well. Here's another case. So this thoracic outlet syndrome is due to this very tiny space in between the clavicle, the first rib, and the anterior scalene muscle and the middle scalene muscle. And you have the brachial plexus, you have the arteries, and you have the vein. And the most common cause they say is neurogenic, but the most common causes that I see are vascular, and venous is much more common than arterial. So if the vein's not yet, or the artery's not yet occluded, you put them through certain maneuvers to try to occlude the vein. So if we're looking for arterial, we'll do these maneuvers with a cuff on their finger to see if their arterial flow flattens out. If it's venous, you do it at the time of ultrasound. And this is our program of maneuvers if you order a venous thoracic outlet study or an arterial thoracic outlet study. A neurogenic thoracic outlet, there's no vascular test that can diagnose this, and there are in fact no tests that can diagnose it because EMGs are normal. It's very difficult to tell if they really have it. Now I want to finish with this, and hopefully you have time for some of the bonus questions. Think of less common causes of heart and vascular disease. You're in the cath lab. You're doing thousands and thousands of patients. Every single patient has atherosclerosis. And so everybody has acute coronary syndrome, has athero, gets stented, gets put on dual antiplatelet therapy, high-dose statin, etc. But not every patient has that. And this is an example. A 46-year-old, twin pregnancy in 2017. She developed hypertension during pregnancy, which persisted. She had sharp pain and shortness of breath. She went to the emergency department at another hospital. And she had a STEMI in the anterior leads, troponin of 14. While they were taking her to the cath lab, she arrested and needed defibrillation 4 times. So some of these patients actually present with sudden cardiac death. And she has no cardiovascular risk factors and no physical or emotionally traumatic events occurred. So here's her right coronary. And I want you to note that many of these people have extreme arterial tortuosity. And there are still people who are reading cardiac caths as the arteries are tortuous, probably secondary to hypertension. And that is just not true. Tortuous arteries like this are not normal. And they occur in a large number of patients who have SCAD, spontaneous coronary artery dissection, or fibromuscular dysplasia, or other genetic diseases like Ehlers-Danlos type 4, et cetera. And you can see here that you have a normal artery, normal LAD, and you come down, and this just kind of tapers to nothing. And you want to try to treat these patients conservatively if you can, but she arrested, had to be defibrillated. She has poor TIMI flow, and she's clinically unstable. So you have to intervene on a patient like this. This is a patient that Dr. Osama Samuels saw and has been taken care of. He sent her to me for the issue of whether or not she has fibromuscular dysplasia. And you can see this marked tortuosity. This is important. This increases the risk of recurrence. Tortuous coronary arteries increase the risk of recurrence. So they put a wire down, they stented it, looked pretty good. And she actually has good flow down into the apex. She, as many of these people, she was discharged. She came back the next week with chest pain and arm pain, went to the ER, her troponin was 3. A repeat angiogram showed poor flow to the distal LAD and poor left ventricular apex contractility. This was not treated. She was put on Coumadin for 1 month, as well as aspirin and ticagrelor. And then she had a third visit 3 weeks later. And this is a very common thing in these people with SCAD, where there were no EKG changes and she had a normal troponin. So these people all need to be investigated for the presence of fibromuscular dysplasia. And depending on the series that you read, anywhere from 60 to 75% have it. Why is it so important to know if they have it? Because 40% of people with fibromuscular dysplasia have an aneurysm or a dissection somewhere. And on her carotid ultrasound, you can see this is up above her ear where she has this extreme arterial tortuosity and ectasia of the blood vessel. And on the renal artery duplex ultrasound, you can see here, actually, you can see some beating present. And you can see tortuosity and turbulence to flow. So because 41% of these people have an aneurysm or a dissection somewhere, it's recommended that every patient with SCAD and every patient with fibromuscular dysplasia get a one-time head-to-pelvis imaging. We like CTA. Its image resolution is better. You can miss FMD with MRA, and the quality of MRs vary considerably among centers, whereas most places can do a good CTA. And what you see here, actually, this is the left side. I couldn't get this all in one view, but what you're seeing is there's tortuosity, and then there's this small aneurysm here that needs to be followed. So this is important to know. Should she want to get pregnant again, which she doesn't, but should she, her risk of aneurysm rupture increases. And this is her right internal carotid artery. This is very high up. This is the angle of the jaw here. So to see this on ultrasound, you really have to angle up and go behind the ear. And this needs to be followed because you want to make sure this doesn't expand at all. And this kind of thing can be associated with dissection. It can cause pulsatile tinnitus. It can be associated with migraine headaches. She had bilateral medial fibroplasia or multifocal fibroplasia of the renal arteries. And here's an example of tortuosity in the aortoiliac segment and this so-called string of beads in the external iliac artery, usually asymptomatic, but occasionally produces hip or thigh claudication. But she also has 3 other aneurysms that need to be followed. So that's the importance of doing, head to pelvis imaging. Now it can be done at one time, but you need 2 injections because blood's flowing in opposite directions. We prefer to do a neck and head and then bring them back a week or 2 later and do a chest, abdomen, and pelvis. And I'm sorry, I'm not supposed to go back here. But I spent a lot of time with this patient. I'm just going to summarize this. These people usually need to see a therapist. There's a very high prevalence of post-traumatic stress disorder. They get recurrent chest pain, and she was beyond anxious and was having panic attacks. And I think to make matters worse, I think her husband left her, 6 months later or something. So here are the 3 major types. This is Jackie Saul's classification scheme. Here you actually, on the left, you see, I'll show you an example of this. You see the dissection flap itself. Here you have long, smooth, narrowing, normal artery, long, narrowing, normal artery. And here you have a very focal or tubular stenosis. I agree with this, but she misses out on this type of SCAD. This type of SCAD is you have a normal artery and then it just tapers down to nothing. You never come back with a normal artery. This is with her type 1, and this is with her type 2, which is an intramural hematoma. This is from our paper on coronary manifestations of FMD. So here's type 1. You see a nice dissection flap. OCT, you can see the true and false lumen. Type 2, you see normal artery, long, smooth, narrowing, normal artery. There's nothing else that can cause that. When you see normal, abnormal, normal, it's always a dissection. And these things heal the large majority of time. And this is a type 3 dissection, a very focal area of stenosis. Look at this tortuosity that this patient has. Again, normal artery, narrowing normal, occurs at a hinge point, abnormal, normal. So in our FMD registry, this was when we had 966 patients, 22%, and all these patients didn't even get head to pelvis imaging. We're doing that now, and this number's up around 30 or 35%, and we have nearly 3,000 patients in the FMD registry. So aneurysms in this series occur in 22%, mostly in the renal and the carotids. Intracranial, they have a high prevalence of aortic aneurysms for premenopausal women who have never smoked, but you can get aneurysms anywhere. And then dissections, this is a carotid dissection, this is a vertebral artery dissection, occurred in 26%, and the carotids and vertebrals are the most common places, followed by the coronaries and the renals. And I actually think this number is going to increase because when we started the registry, in 2008, we didn't even know about SCAD. Nobody was recognizing it. And we've gotten really, really good at ultrasound in going all the way up to the skull base. So when you see these still frames that many ultrasonographers do, you can't get information like this. And if they're just looking at the carotid bifurcation, you're going to miss lesions like this. So Dr. Kadian was the first author on this paper of aneurysms and dissections in patients with FMD, and 41% had one or more aneurysms and/or dissections. Fortunately, only a small percentage of people have 0 to 1 TIMI flow. And generally, this is overly simplistic, but generally you want to, if they have SCAD, do a TIMI flow assessment. If they're stable and their TIMI flow is 2 to 3, conservative management. If they're unstable or have TIMI 0 to 1 flow, revascularize. If you're not sure, do an OCT or an IVUS to pick up an intramural hematoma. Can you prevent recurrence? The recurrence rate is 10 to 20%. In this paper published by Jackie Saul, the use of beta blocker therapy was protective, and patients who don't have hypertension have a lower rate of recurrence. And if you have significant arterial tortuosity, you have a higher rate of recurrence. All right, I think I have 5 or 6 minutes. So why do these patients get hypertension? Would anyone like to guess?
Get that. Try tapping above to edit.
Siri didn't get it. Does anybody know what this is?
Do you know von Recklinghausen? Was he a German or a Dutch?
That's a good question, George. So you think this is neurofibromatosis, right?
Yes.
He's saying yes. So this is neurofibromatosis. And they get hypertension because they get renal artery disease. So that's one of the causes of renal artery stenosis, neurofibromatosis. Now, granted, not in an extreme degree like this, but many people have mild degrees of it. But if they have hypertension, look at the renal arteries. This patient is 33. She comes to see you because something is terribly wrong. She saw a vascular doctor and he said, you have something really wrong with your circulation. So she came for another opinion. She has no pain. What is it? It's hard to do this by Zoom because you can't look into somebody's eyes. But I see a number of people who have been on my service. Anyway, sorry. That is benign livedo reticularis. Okay, there are secondary forms of livedo. This is the fishnet pattern, the reticular pattern that occurs mostly in women, mostly trim women, and it's due to vasospasm of the dermal blood vessels. It's not dangerous. It requires no treatment. Don't let somebody do sclerotherapy and inject these. Most people don't like this because they just don't like the cosmetic appearance of it. If you gave a calcium channel blocker or rewarmed the patient, this would disappear, but many of these patients are walking around outside and their legs look like this. Benign livedo reticularis. What's the name of this vessel? Well, I think we all agree this is the aorta, this is the cava. Does this patient have 2 aortas? So, and then what are the names of these vessels? I show this because this is not common, but this is fairly common. So this is the superior mesenteric artery, and it's got an aneurysm. Now, how do you know that? Because the left renal vein crosses anterior, and when it crosses anterior to it, the SMA is seen in cross section. So this is an SMA aneurysm, the size of the aorta. And many people don't recognize this, that the right renal artery often comes off at the same level as the superior mesenteric artery. So I think that's an important concept. Now, in order to get the Harley Softail with leather bags that I was going to give to whoever got the most number right, you have to get all 4 of these right. So the first question is, what's the name of the blood vessel I'm showing you here? Anybody want to guess? So this is
The wandering artery of Drummond?
No. Was that you, Lindsay?
Yes.
No, but good guess. Wandering artery of Drummond comes out further, and the arc of Relan comes closer to it. But this is originating in the renal vein. So this is the gonadal vein. Okay, and when you see a really big gonadal vein like that, let's see what the next question is. Okay, so what symptoms do patients have? If you're a woman, you may have symptoms of pelvic congestion syndrome and achiness in the pelvis. If you're a man, you may not have any symptoms. Why is the blood vessel so large? Because what's causing this is shown on this slide, and this is the left renal vein. It crosses anterior to the aorta most of the time, and here you see the superior mesenteric artery in cross section. So this is nutcracker syndrome, and the left renal vein is compressed in between the aorta and the superior mesenteric artery. This is one of the compression syndromes that you see in the belly, along with median arcuate ligament syndrome. If it's symptomatic and you have somebody really, really good, you can put a stent in there. But it takes IVUS to make sure the stent is placed perfectly so it doesn't go into the inferior vena cava or cause other problems. This person was stented, and his symptoms were completely ameliorated. He had flank pain and hematuria. Last one. What's your diagnosis? Everybody should get this. There's a focal area of stenosis here. So focal fibromuscular dysplasia. What age does it occur in? This is wrong. It's age 16 to 28. I don't know why I did that. So this occurs generally in women 20 to 33 or so. So whereas multifocal occurs in older people. Which of the following symptoms or signs? Let's see here. Which of the following symptoms or signs is the patient most likely to have? I think everybody would say hypertension. Anything else? Yes. A small kidney. The string of beads fibromuscular dysplasia does not cause renal atrophy. This type does, however, and can lead to chronic kidney disease. So it's very, very important that this be treated properly, because otherwise the patient will end up with a kidney that's like 4 centimeters and non-functional. And then how would you treat the patient? Even if their blood pressure was normal, you would do an angioplasty. And the reason is to preserve renal function. We try to avoid cutting balloons in this situation, because there's a high rate of renal artery rupture if you use a cutting balloon. Sometimes you cannot take care of the gradient with a stent or angioplasty. In that case, they need to go to surgical revascularization. So I think we're out of time. I'm happy to answer any questions in the 1 minute that we have.
Jeff, that was great. That was fantastic. Jason, in your group, recently wrote about the genetics of fibromuscular dysplasia. Do you want to just talk a little bit about that, and then screening of family members?
Yeah, I mean, there's been very, very little work on the genetics. There have been two things that Jason, I, and Dr. Kadian have been involved in. One is a paper demonstrating, this was published in PLOS Genetics, that PRACTA1 gene locus is associated with fibromuscular dysplasia. We also participated in a SCAD paper published in JACC that showed that that same gene locus, PRACTA1, is involved in SCAD. And Stephanie DeBette, who runs the CASDIP registry for carotid dissections, published a paper in Nature Genetics showing that PRACTA1 is associated with carotid dissections. So these things are all interrelated in some way. The study that we have been doing is we've been taking a piece of skin from the back of the arm and growing fibroblasts, and we've been taking blood for DNA analysis. And for every patient, we have a control patient who we see in the clinic. We examine, we talk to them. If they have any suggestion of FMD, we image them. And we've now identified 3 controls who ended up having fibromuscular dysplasia. And in the paper you're talking about, he looked at the protein signature, the proteomic study of the signature from the fibroblasts, and demonstrated a number of upstream genetic upstream genes, and when combined with a lipid analysis, if you put those two together, you can take blood and there's a sensitivity of 77%, specificity 75, positive and negative predictive values in the 70s, that you can tell whether the patient has FMD. It's not good enough to use. It's really just the beginning. Our funding is drying up, and unless we get more funding, I don't know how much longer we'll be able to take this forward. But Jason has one R01. We submitted a second R01. We'll see if it's funded.
Thank you. Are there any other questions for Dr. Olin after his fantastic talk? Dr. Kate?
Marty, may I ask you, is this archived somewhere so I can disseminate to my medical students?
Yeah, so this is being recorded, and Dr. Sharma has provided with Kimberly Custy. We're going to put a COVID section on CC live cases.
Fine. Okay. No, that's fine. I don't want to get that. I'll follow up with Kim then. Okay.
Yeah.
Very good. Thank you.
Again, Dr. Olin, thank you very much. Any other questions? Jeff, this was great. Appreciate it very much. Everyone have a great day, great weekend. Be well. Thank you very much. Jeff, fantastic.
Okay, thanks, guys. It's been a pleasure.
Thank you.